Greetings. I'd like to welcome you back to the Ensuring Clinician Wellbeing in an Age of Uncertainty, Emerging Lessons from the COVID-19 Pandemic and a Systems Approach for the Future meeting. We're happy to have you, and we're really looking forward to this next session, which is entitled Leveraging Data to Impact the Design of Systems for Clinician Wellbeing. My name is Steve Singer. I'm the Vice President of Education and Outreach at the Accreditation Council for Continuing Medical Education. In this session, we're going to hear three really interesting and very different perspectives on the COVID-19 pandemic from three healthcare leaders, Dr. Christine Sinsky, Dr. Beverly Malone, and Elisa Arespacochaga. Each are going to speak to, respectively, coping with COVID-19 for caregivers, confronting racial disparities perpetuated by structural racism during COVID-19, and also the financial pressures of COVID-19 on hospitals and health systems. Our goal in exploring these topics over this next hour plus is really to examine how data that is arising from this experience on the health, social, and economic impacts of COVID-19, what import they hold for addressing well-being, and also their evidence for the cumulative effects of other factors like structural racism, unconscious biases, system factors, all on the outcomes within the system that we're seeing now, and hopefully sort of reflecting back to Pascal Carion's conceptual description in the earlier talk, how we as a learning system can incorporate these findings, sort of back into our own planning as we tackle the continuing pandemic and also look to the future of how to address clinician well-being in the frame of improving care. So in order to just begin the session, I'd like to begin with introducing our first speaker, Dr. Christine Sinsky. Chris is the Vice President of Professional Satisfaction at the American Medical Association. She's a board certified internist, and she's also a member of the Board of Trustees for the American Board of Internal Medicine Foundation. She has worked to improve opportunities for joy, purpose, and meaning in work with several important publications. And without further ado, I'd like to introduce Chris to give her presentation.
Great, thanks so much, Steve. I'd like to share my screen, and I need to have someone else stop sharing theirs so that I can do that. There we go. Wonderful, thanks so much. And it really is my pleasure to be speaking with you about caring for the caregiver during COVID. We also address this as creating a resilient organization, and you heard that term from Dr. Nevin, and pleased to hear it. So our agenda for this 10 minutes is to go over a model of caring for the caregiver that we've developed in partnership with experts in the military. Share the results of our Coping with COVID survey so far. We have about 45,000 respondents to this survey. And then to share some of the resources that we've made freely available at the AMA that are relevant to creating a resilient organization. So first, the model. We have a crisis. At this point, it happens to be a pandemic. That crisis naturally leads to stresses. At this time, it's personal and family safety, feeling overworked, grief and loss from losing patients, from losing coworkers. These are natural parts of the crisis which lead to stress injury for all. Anxiety, difficulty concentrating, overwhelming fatigue, trouble sleeping, feeling guilty. That's stress injury. But what we know can happen is without any intervention, that can go to developing a dysfunctional chronic stress reaction, higher rates of burnout, an intention to leave the profession or reduce work effort, depression, substance abuse, and most tragically, death by suicide. But that's not the only pathway available. As Dr. Farley mentioned, it is possible to have post-traumatic growth. So after the crisis, the stress and the stress injury, to move to a point of coping and recovery and even thriving. And what's unique about this crisis is that it's not just a one and done crisis, that it is actually, as Dr. Nevin said, it's not a sprint, it's not even a marathon. And she used my favorite example, which I hadn't thought about. She called it an Ironman triathlon. I happen to keep my pens in such a cup, having completed one a few years ago. So the challenge is there's no clear endpoint here to this particular crisis. So what are some things that can cause our organizations to be more resilient, to cause our organizations to be able to protect and support the individuals within? Well, a couple of things. One is pre-existing institutional supports, and we heard wonderful examples of that. And I know that from speaking with the leaders at Christianicare and from a few years ago, having visited with Dr. Lewin and his executive staff at Emory, that they were both early adopters of the importance of having a well-being infrastructure, having a communication plan, maybe even an ethics program, perhaps having a structured approach to human-centered leadership. Once the crisis has happened, being able to provide stress first aid. And again, we've heard many examples of that, meeting basic needs for housing, for transportation, for food, providing 24/7 psychosocial support. This can even be providing a mechanism for the buddy system, then transparent and bilateral communication. And then one we heard a little bit about, and that is taking an opportunity of a crisis and providing some regulatory relief. So a time to de-implement policies that were well-intended at the beginning when they were implemented, but now perhaps add so much sludge to the system that they make it hard for our caregivers to do the important work. And then recovery aid. Exactly as Dr. Lewin said, time away, rest, knowing that people will need counseling for 6 to 12 months, need availability of counseling for 6 to 12 months after the crisis has passed. And another action that we recommend is measuring how people are doing. And so I wanted to tell you the story of our development of the Coping with COVID survey at the AMA. So when COVID hit, we rapidly pivoted from deploying a burnout assessment tool to a Coping with COVID survey. It's something we do at no cost. It's part of our mission work at the AMA. You can find out more information and sign up at clinician.health. We have done this in 70 healthcare organizations, more than 70 now. We have more than 45,000 respondents across all role types. It's both clinician and non-clinician staff. So we have housekeeping and kitchen staff, as well as nurses and physicians and others who are queried in this. And I wanted to share with you what we've learned from our first 30,000 cohort. What we learned, not surprisingly, is that fear of exposure is high, over 60%, that anxiety and depression related to COVID is also high in over a third of our workers. And stress is highest among our housekeeping staff, our nursing assistants, and our nurses, and also among persons of color. This has implications for the workforce. We know from experiences with earlier pandemics and earlier infections, say with MERS, that there's a threat to the workforce. From our study, from our survey, 20% intend to reduce to part-time within a year, 30% intend to leave within 2 years. But all is not doom and gloom. There are protective factors, and we heard reference to this from some of the earlier speakers. But feeling valued by your organization and having a strong sense of purpose were protective against stress and protective against anxiety, depression, and burnout. We also had a free text question, and so the top 5 areas where our qualitative responses were around financial security, lack of PPE, the need for transparent communication, and on the positive side, a reignited passion for healthcare and the value of peer-to-peer support. So with that, I'd like to turn to some of the resources that we have available at the AMA. At stepsforward.org, we have over 60 toolkits that are available. They're practical, actionable, one-stop resources for all you need to implement a particular approach, with case studies showing the variation on the theme at multiple organizations. So one that Dr. Rip was mentioned earlier, CWO at Mount Sinai, Dr. Tate Schoenefeld, who is a CWO at Stanford, Dr. Marie Brown and myself wrote, is creating a resilient organization, caring for the healthcare workforce during crisis. And again, it's a very step-by-step approach with downloadable resources to support an organization that wants some guidance. We have others. One of my favorites is Getting Rid of Stupid Stuff. And it's based on the New England Journal article of the same name and a program that was implemented in Hawaii. Again, a step-by-step approach to decluttering an organization of things that were well-intended and may have had a purpose 10 years ago, but may no longer be providing value. And then we have a lot on organizational culture and practice efficiency that also then allow our clinicians to really devote their time not to documentation and EHR-based tasks, but to patient-focused tasks. And as I mentioned, each one has case studies or success stories, and these happen to be the 10 or so success stories that we have associated with the caring for the healthcare workforce during crisis. And you will see some familiar organizations represented there, including Christiana Care. So I'm going to end my portion here with a slide from Ochsner Health in New Orleans, who has not only had to deal with COVID, but also with a lot of hurricane threats this season. And our people are the key to our success. Well-being is the key to theirs. And I will share with you that I believe that the shortcut to the quadruple aim, the shortcut to the other outcomes that we care about, quality of care for individual patients, health for the population, cost that we can afford, is through focusing on clinician well-being. And with that, I will turn it back, Steve, to you as our moderator, and on to our next speaker, whom I believe might be Beverly.
Thank you, Chris. That was a tremendous presentation. And I particularly, it was interesting to see the way in which the survey is speaking, not just to a clinician sort of audience, but also a broader workforce audience. Now we're going to continue with introducing Dr. Beverly Malone from the National League of Nursing. Just a brief introduction about Dr. Malone. She is President and Chief Executive Officer at the National League of Nursing. Under her leadership, they have advanced the science of nursing education by promoting a greater collaboration among stakeholders, increasing diversity in nursing and nursing education, and advancing excellence for the care of patients. I could spend much of the webinar talking about Dr. Malone's distinguished career, but she has been involved both in policy, education, administration, and clinical practice, including as Federal Deputy Assistant Secretary for Health under President Bill Clinton. Beverly, I would like to invite you to begin your presentation. Oh, you're muted, Bev.
Good afternoon, colleagues.
Thanks. Can hear you now.
Very good. Structural racism refers to interconnected institutions whose linkages are historically rooted and culturally reinforced. It is the totality of ways in which societies focus racial discrimination via mutually reinforcing inequitable systems of beliefs, systems, and distribution of resources. Both African Americans and Native Americans fit clearly into this category. I will speak primarily about African Americans. While I could go back to the founding of colonial America, let me begin with a medical terminology that was used to continue the idea that Blacks were less than whites. Drapetomania was described as a mental illness contracted by slaves who ran away. There was a consistent effort to rationalize the behaviors of those who were white and were slave owners, supporting the economic and ethical concept of slavery. If a slave ran away, it was caused by a mental condition, and the mental condition was drapetomania. A second example of structural racism that included the entire country was the 3/5 clause of the United States Constitution of 1787. Even today, it is described as misinterpreted to mean that African Americans are, as individuals, were considered 3/5 of a human or 3/5 of a citizen. The argument was that the clause addressed only enslaved Blacks in a state who would be counted as 3/5 of the number of white inhabitants of that state to determine representation in Congress. Yet the data highlight the continuation of these macro aggressions, such as Jim Crow laws. These were enforced only yesterday. At least that's how it feels. When I was growing up in Kentucky, and for example, I was denied the right to drink from a white person's fountain of water. I never went inside a hospital until I was a candy striper. And that I was about 16 at that time, and never for any illness. My great-grandmother was the community healer, and we had heard stories of Tuskegee and other strange tales of horror where Black people were experimented on. This kept our community lacking any trust in the healthcare system. The nurses and doctors were all white, and the hospital was on the other side of town, miles and miles away from the railroad tracks that divided the white and Black sections of our town. And of course, today, the structural racism continues with mass incarceration, segregated housing, killing of Black men, and I have to add women, the Louisville, Kentucky, Breonna situation, and the pandemic of COVID-19. PowerPoint number 1 shows the racial disparities, and not all of them, connected to structural racism. Just a few: poverty rate, your household economics, household, unemployment rates, prisoners, and all of them show this incredible distinction between white Americans and Black Americans. Life expectancy, infant mortality. And then if you go to PowerPoint number 2, it gives a clear depiction of one of the contextual events that strengthened Black Lives Matter's civil protests and marches around the world. Just the fact that it's probably about 3 times almost whites in terms of killings. And I don't even know how you are happy about that at all, but that is the data, that are the data. The COVID-19 data show that those who work in essential roles are more likely to contract the disease, and Black Americans do contract the disease more frequently than white Americans. Slide number 3 highlights risk markers for other underlying conditions, you know, your socioeconomic status, access to healthcare, increased exposure to the virus, all of those things are there. Blacks are nearly 3 times more likely than whites to do work in healthcare support jobs, such as nursing assistants or orderlies. And Chris, that was an interesting survey because of showing that nurses and nursing assistants, and so that just kind of fits into what I'm saying at this point. The funny thing about this presentation, I would talk about Blacks 1 minute, and then I would be talking about we the next minute. So you'll have to take that as part of my recognition that I'm part of the Blacks. And so it just automatically slips out in terms of even reporting the data. We are twice as likely to work in transportation roles, such as bus drivers, movers, and taxi drivers. Overall, among combined states, the prevalence of Black deaths from COVID-19, it's about 21%, is disproportionately higher than the non-Hispanic Black unweighted US population, which is 12%. PowerPoint number 4, can you show that one, please? Thank you. Clearly demonstrates that throughout the US, there are 2.6 times more cases, 4.7 more hospitalizations, and 2.1 more deaths of Black Americans than white Americans. This trend was also seen within 26 states and DC, with a discrepancy between mortality and population highest in Wisconsin, a battleground state, and Kansas. For example, while Blacks comprise 6% of Wisconsin's population, they comprise 36% of the state's COVID deaths. In Michigan and New York, they comprise 40% and 15% respectively, and while representing 14 and 9% respectively of New York's, the state's population. Racial and ethnic disparities in healthcare are known to reflect access to care and other issues that arise from differing socioeconomic conditions. There is, however, increasing evidence that even after such differences are accounted for, race and ethnicity remain significant predictors of the quality of healthcare received. In the landmark report, Unequal Treatment, conducted and issued by the IOM, they conclude with recommendations for data collection and research initiatives. These recommendations in 2003 are still valid today. They include improvements in medical care financing, allocation of care, community-based care, and I would add redesigned educational curricula and re-educated faculty in the area. In a more recent, September 2020, that's how recent this study is, the Kaiser Family Foundation and the Undefeated, that's a title of an organization, polled 1,769 adults, including 777 African Americans. They found African Americans to have low levels of trust in their doctors and the healthcare system. And if you remember, just a few minutes ago, I talked to you about how low the level of trust was when I was growing up. So it's been a number of years, colleagues, since that happened, and things have not changed significantly. Black people in the poll reported higher rates of being disbelieved and of being denied tests, treatments, or pain medication they thought they needed. Our responses reflect, I'm back to the our responses reflected an old saying, when white America catches a cold, Black America gets pneumonia. COVID-19 places a strong spotlight on these issues as the death rate continues to climb, accelerating in areas where the availability and access to care is challenging. Steve, I'll turn it back over to you at this time and welcome Elisa.
Thank you, Bev. This is a very important presentation. And I just want to remind the folks in the audience that you can, we're going to move forward to Elisa's presentation, but I would welcome you to submit questions or discussion suggestions for our open panel discussion that's going to follow these presentations. So if you have questions for Chris or for Bev on the slides that they've provided so far, you're welcome to chat those in, and we're going to look forward to a discussion shortly. So, you know, rounding out again, the very, very different perspectives on the challenges, and Bev, to your point, the impact of structural racism on health disparities is not a new story whatsoever, but COVID-19 has certainly cast a harsh spotlight on those disparities.
Yeah.
So now, kind of coming around to yet another perspective of the challenges of COVID-19, I want to invite Elisa Arespacochaga from the American Hospital Association to present. Elisa is Vice President at the AHA's Physician Alliance, which is a strategic initiative launched as part of the AHA's ongoing mission to improve the health of patients and communities. In her role, she is responsible for the work of the Alliance to build relationships with clinical leaders around physician leadership, resilience, well-being, managing populations and providing high value care. So Elisa, you're certainly in the right group. You're in good company in this day. So Elisa, I'd like to invite you to go ahead and present about the financial challenges to the healthcare system.
All right, thank you so much, Steve. And as you can see from my headshot, COVID has at least resulted in a lot more hair. So thank you, and thanks to my fellow presenters for really painting two of what I think are now going to be the three pandemics that we're seeing happening in addition to COVID. We're entering the third quarter of COVID. Someone referred to that yesterday, and it's stuck with me since. What I'm hoping to do today is just talk a little bit about the financial impact we've seen across the nation to hospitals, some of the things that hospitals and health systems are still facing, and then a couple of stories about what this means from the front lines of healthcare. So if you could go to the next slide. Thanks. So before we get too far into this, it's really important to remember that in January of this year, before COVID-19, 1/3 of hospitals and health systems operated in the red. So there were already financial challenges that were underlying much of our work. And one of the reasons is that Medicare and Medicaid has historically paid less than the cost of providing care. And about a little over half of the hospitals across the country, about 50% of their revenue is from Medicare and Medicaid. So you see in this graph, that's Q1 2020. I realize the numbers across the bottom are hard to read, where hospitals operating with a negative margin hit nearly 50%. And the projections that go out into the end of this year look like that'll go above it. This pandemic is one of the greatest financial threats for US hospitals and health systems. Next slide. And part of the reason for this, we've just heard from some of my colleagues, both preparing for the surge, whether it was acquiring enough PPE to keep their teams safe, which, at least early on, those were costs that were astronomical. Ensuring that we had enough team members coming in to help spell those who needed to take a break, those who were exposed to illness, who needed to be at home quarantining, and making sure that we had enough folks in place to care for the communities, making sure those resources were in place to support our teams, whether it was providing hotel rooms or, as I know Heather mentioned at least once, the idea of having scrubs available to all employees so that they would feel safe going back to their homes, being able to shower at their organization and not feel they were bringing COVID home. And then all the infrastructure needs and upgrades to be able to support communities in caring for COVID, whether it was putting up tents for testing in the parking lot, which now I'm guessing are going to need heaters to go with them, to all of these other resources that were needed to be able to respond to the surge. I think Iron Man is really the perfect way to describe this, because we are continuing to have to put this forward. At the same time, you had this sort of triple threat coming together of preparing for the surge and making sure you had all these resources, combined with whether they were shutdowns or slowdowns in outpatient care, in non-emergent care. So the healthcare system really contracted to be sure we'd be ready, but much of the revenue, and you'll see on the graphic, the outpatient volume decreased dramatically at the beginning of this and still has not recovered. And then add to this, besides the fact that obviously the economic impact on our entire country and world with the rising rates of uninsured who needed treatment, but the increasing need over the last months, especially for mental health care services, not only to support our caregivers, but to also support our communities. That was already an area that was stretched thin. I think Steve said it earlier that none of these areas were new as a result of the pandemic, but the pandemic has really highlighted where our gaps might have been. Next slide, please. So the AHA has published several reports. You can find them on aha.org. And dig into a lot more details than I'll provide today, but just to give you the top line numbers, the report that we published in June estimated a minimum of $120 billion in financial losses, largely due to lower patient volumes from July through December. So that's an average of about $20 billion a month in losses just from July to December. And that's at the hospital level. That doesn't count for, and I'm sure everyone on this call has seen the same reports I have around physician practices closing and being challenged with losses. And those estimates are in addition to the $202 billion that we estimated that was lost between March and June. So we're looking at $323 billion being lost from the healthcare system over the last months. Next slide, please. One other thing I want to point out about this, and this is from an analysis that was done by Kaufman Hall, which we also have available on our website, and this is from July, that without further government support, so without more support to hospitals, average hospital margins could sink to a -7% in the second half of 2020, with more than half of hospitals operating in the red, which is just not a sustainable situation. And as I said, part of this is really due in part to hospitals seeing fewer patients. We found that inpatient visits were down nearly 20%, outpatient visits nearly 35%. And we're not seeing signs that those volumes are going to return to previous levels in 2020. Refuse to say normal. I think we've lost normal. We've also found that, and this is alarming to me, that emergency room visits continue to be down over 18% as of August, and I'm sure they're staying there. And what heard a quote yesterday that we're seeing increases in EMS workers attending to deaths in the home, that number is increasing significantly as the public is still concerned about returning to the hospital. So that is adding to the challenge. And now with this, if it's our third resurgence, we're seeing the potential for additional reductions and scale backs to non-emergent procedures as hospitals again prepare with their caregivers to understand how they can be ready. The last thing I'll point out on this is that volume returning is very variable depending on which service line it is. In some areas it's returning or has maintained as those who are undergoing cancer care continued, while cardiology services are down by nearly 30%. Next slide, please. So as I mentioned, that's $323 billion of projected losses. Now, while we very much appreciate all the support from the administration and Congress to bring relief to hospitals and health systems and our providers, there's more to be done. Certainly there's need for additional funding for the Provider Relief Fund, additional support for our healthcare frontline, many great examples mentioned over the last couple of hours, and maintaining those benefits for individuals and families and increasing the options for coverage for those who are uninsured. Next slide. I just want to leave you with a couple of stories. There are many more of these available on aha.org, but these three struck me as three very different impacts to three very different hospitals. The first in Ellensburg, Washington, their rural critical access hospital. They're outside of Seattle, where some of the first cases were reported. And their CEO is quoted as saying, "Our revenues and volumes fell off a cliff." Their ED volume plunged 40% in March, while most of their outpatient visits disappeared, except for mental health volumes, which surged to more than 35%. And they continue to be challenged in understanding how they can bring back the care that they are able to provide. They're only scheduling 2 weeks out at a time because they're concerned about needing to be prepared for the next surge. Next story is from one right down the road from where I'm standing here in Chicago at Loretto Hospital, which serves Chicago's West Side. And much to Beverly's point, this serves a predominantly Black community that has been hit extremely hard. This community hospital shut down their outpatient and non-emergent services, and 70% of their admissions in April were for COVID patients. By July, they still hadn't restarted non-emergent procedures, and their occupancy was still at around 75% with COVID patients and comorbid patients, and then patients from their nursing homes in the area. And they have been extremely challenged to meet payroll. They had to take a small business administration loan to be able to continue to move forward. And they are very much challenged in their community. And all of this is not happening in isolation. Chicago has certainly seen quite a lot of social unrest as these conversations have continued around structural racism. And that has also impacted their ability to care for their community. They've had over a weekend at the end of June, 54 shootings in their neighborhood. And the last one I'll talk to you about is UR Medicine Thompson Health, which is in upstate New York. So in March, when the New York government shut down, they had 80% of their revenue disappear. It was largely outpatient. They prepared, they were ready for a surge, they redeployed staff, they did all the things you've heard about, but they are struggling to make sure that they can get through the end of the year, supporting their teams, especially their frontline workers who are facing challenges related to childcare, housing, transportation, while trying to still provide care for patients. So with that, Steve, I look forward to the discussion that's going to follow.
Thanks, Elisa. So now, thank you for your presentation. Thanks all three of you for highlighting these different perspectives. Each of your presentations by design were utilizing data, taking advantage of the opportunity of data to really highlight the environment that we're in. And I want to start with a question that I'm going to direct to all three of you. And I really appreciated the opportunity to have a planning call with the three of you. And Bev shared a great quote that I can't help but share as a way to frame this discussion. So Reverend Dr. Martin Luther King Jr. said, "We may have all come on different ships, but we're in the same boat now." And I think this statement really captures the environment that you're describing, each of you, for health professionals, organizations, their leadership, their communities at this challenging time. What is unique, I think, about this time is the fact that so many organizations, all of our organizations, are navigating these challenges simultaneously. In contrast to episodic crises that may affect one organization or community, or another at different times, can you each explore what opportunities you think we can draw from this collective experience of the pandemic? I don't want an award for our three presentations being the most concerning three presentations of the day, but to try to find a silver lining that comes from having so many of us seeking to solve these enormous challenges at the same time. So maybe, Bev, can we start with you to just ask, what can we learn from each other, and how could we facilitate learning and improving around those insights to help not only our own communities, but across our community of organizations nationally? Bev, you're muted again. Sorry about that.
Steve, thank you. And I'm again just really amazed at the presentations by my two colleagues, because it does say that we're all in the same boat now in so many ways. But from my perspective, the opportunity to have this discussion is rare. And it's a silver lining that we actually are even discussing the 3/5 human. I can even say that, without someone saying, oh, how un-American you are, instead of saying, well, that's just the truth. And to have conversations where you feel safe enough and authorized enough, and not just me authorized, but my colleagues authorized enough to explore these issues together and to say, in our institutions, what can we do differently to make sure there are safe spaces for these conversations as we talk about healing, as we talk about our providers doing better in our schools, in our universities. How are we going to have faculty who are brave and bold enough, with enough courage to have that dialogue with their students, their healthcare students and other students? So I think that it gave us permission and authorization to be able to talk in a safe place. Christine, you said something about having safe places to talk. Well, we haven't been authorized frequently. It's a no, don't do that. And it's an unspoken no. So, those are the worst kind. So I think this is one of the silver linings.
Thanks. So Chris, looking from the data set that you've already explored with us, and the opportunity, not just for an informational sharing with other institutions about what the data is telling you, can you speak to what you see as sort of collaborative or improvement priorities that we can take more systematically from our collective experience?
I appreciate the question. And I do think that 2020 has been such a pivotal year, and we won't even recognize how pivotal until a few years down the line. But as I've heard people refer to it, the plague, fire, and fury of this time. And so I think it gives us an opportunity for a reset, for first a consciousness raising, but then for actual action. And so I'm thinking of how I had the opportunity to interview residents and other leaders in New York City for a different presentation and about their experience, particularly those who had March and April surges and just didn't know what was happening, what was coming. And one of the things that helped bring those people up, lift them up, was being part of something larger. So when the Black Lives Matter movement began, and there were white coats for Black lives, that actually helped heal some of the caregivers from some of the PTSD, if you will, of the initial surge. And so I think we just have this opportunity where everything's on the nothing's off the table for what we can change. And a colleague and I wrote a paper on policy and practice reset post-COVID. And I think that there's just a wealth of opportunity to clear the system of inequity, to clear the system of sludge that contributes to inequity, and to bring thought leaders and bring practicing leaders together to make these really substantive changes.
Thanks, Chris. And I'm sure we're going to hear more about that in the meeting, but I think the adjustments to COVID with regard to regulatory and policy issues already that we've seen around telehealth, et cetera, demonstrate a kind of a permission for innovation that's sort of forced by these issues. So that's a great point. Elisa, can you sort of contribute to this conversation? It's clear that your work and the AHA are making a lot of what you're hearing and learning available to the rest of the community. But do you have thoughts on seeing that sort of stream of insights about what we might do together to raise all boats?
Absolutely. And I think what both of my colleagues said is very true. This has given us the opportunity to question every assumption about care delivery we've ever had. We have an opportunity to analyze what we keep and what we jettison of our practices that until very recently were considered, set in stone, and many were set in regulation. So I think we have some opportunities, but we also have to very carefully understand, for example, we turned a switch on and turned on telehealth, but I don't think there's either one of my colleagues who are clinicians would say that we need to move entirely to telehealth, that's not the way that they're going to care for patients effectively. And we need to understand what those hybrids are. We've also really uncovered the fragility of the healthcare system financially. And we really need to look at how do we as hospitals and health systems work with our clinical colleagues to design what that next level, that next reality of healthcare delivery is. And I think we've got some opportunity. I think to Chris's presentation, we need to figure out where we can put those pause points so that we can refill our own gas tanks to be able to have that conversation. Because I think people are tired. But I think this is a great opportunity to have those conversations. And I think we're finally in a place where we all see the value.
Thanks, Elisa. So we had a question that was chatted in by Dr. Agrawal. And the question is, perhaps this is an odd question, but one of the pre-pandemic issues was workload around patient volumes. Are there any learnings from this time with reduced patient volumes that you're hearing from about from clinicians? And I would just like to sort of extend that to say, are there any other sort of case examples of things that have been sort of odd results from this sort of lockdown that have given us the opportunity to sort of look at what used to be issues that we were concerned about? Chris, I see you nodding. Would you want to start?
I'll start and see if this is what you had in mind, but I'm thinking of a conversation I had with Dr. Carrie McGrath, who is a wellness leader at her institution at Mass General or the Brigham. Now I'm forgetting which, but one of the Boston institutions, which I guess have merged now anyway. But she leads the respiratory clinic. And what she said is physicians went from hating their EHR to really finding it valuable in a matter of days at their respiratory clinic when they were able to institute some regulatory relief. So instead of having to go through a cumbersome series of drop-down boxes to order a chest x-ray, they could just verbally communicate to a team member that the patient needed a chest x-ray. And they were therefore no longer encumbered by this very time-consuming process when we have trustworthy clinical partners who are completely capable of taking a verbal order for a chest x-ray. And the urgency of the situation allowed that change to happen. And Dr. Shah, who's the CWO at Marshfield Clinic in Wisconsin, said she had a physician who was burned out and really, I think, on the brink of leaving the field, who after COVID began said, I just feel like I'm a doctor again. And so we have that chance to reconnect with purpose, but do it intentionally so that so many of the incrustations that have developed can be removed. Not all, because some have still relevance, but I think it's just time to question and remove some of those barriers that keep physicians and nurses and others from delivering care. And that allows us more capacity.
Thanks, Chris. I'd like to move on to another question. So all three of your conclusions that you shared were buoyed by data-based insights arising sort of before the pandemic, but collectively through the pandemic, and how the pandemic has exacerbated the challenges, inequities, et cetera. Looking sort of to the year ahead, and perhaps if we can, to look kind of at a post-COVID world, I'd like to ask each of you to think about and share what data sets or what measures do you think are critical for our healthcare systems to be measuring going forward? And Bev, I'm going to start with you because I know that, and it's actually one of Chris's colleagues at the AMA, Elisa Maybank, has been very public and spoken a great deal about the need for better, more transparent and active reporting of healthcare data concerning populations of minorities at risk populations, et cetera, to more clearly reveal the disparities. But do you have a thought sort of looking forward, Bev, to the data that we should be looking at most intensely?
Yeah, well, what came to my mind as you were talking were the mass incarceration that's going on, and that seems to be authorized economically as an economic achievement almost. And my concern and my hope that instead that the clarity that it is a hot zone, the way it's run, the way it's managed, the way people are taken care of, and that takes me to nursing homes. So I'm at nursing homes and I'm at prisons and I'm at and providers that we all are taking care of populations that are desperate right now and who are endangered. And I think that the data is like a gut punch. It just hurts so much to see how it affects different groups and how the hot zones are there, and it's punitive, and it makes me want to see a brighter future for us. So there are not those hot zones. So we do some things about reducing the vulnerability of different populations, and I would include the Native Americans, who I didn't talk about, but their data is so close to that of African Americans. And so that's what this opportunity to pivot, this opportunity to say, how are we going to build better, to make it a better thing than we've been doing? And we as providers are in the inside view. We're not looking at it from the outside. We're on the inside looking at this, and we know it can be better. Our children are out of school and they know it can be better. They are talking about how we've got these brilliant children who are moving forward, and nurses, those advanced practice nurses that are not advanced practice, that are right there elbow to elbow with every provider. I think that this is such an opportunity to say, let's run this thing differently.
Mm-hmm. And I think that those data, if they are, you said a gut punch, but if they are aggressively followed and transparent, they also provide a metric or a scorecard by which we can show how we're addressing those disparities and hopefully improving on those inequities. Elisa, do you have a thought about the data that, I mean, you already have a data set, but other metrics?
Yeah, I think a lot of this goes back to, you address what you measure. So I think we need to continue to be tracking related to healthcare disparities, related to the impact of resiliency, related to the financial health of organizations. And all of this we need to continue to gather data in these areas. I'm reminded of I'm going to date myself, but I remember when at the time it was the IOM report, Crossing the Quality Chasm. And this assumption that had sort of existed of the assuming quality. And we realized we needed to step back and measure quality and move forward in a systematic way. And I think we're at that same sort of frontier in many of these areas related to resilience and well-being, related to addressing some of the healthcare disparities we see that COVID has really highlighted. We're at that point where we really need to put actions in place that are going to systemically measure and track where we are, because otherwise it's going to be another project that falls by the wayside once something else pops up as a priority.
Chris, would you like to contribute on this?
Sure, I'm happy to. And I think initially my proposal for measurement in the post-COVID world might seem a little distant from equity and disparities, but I actually think it's directly related, and I'll try to make that connection. And it's under the whole idea of moving decision authority closer to the patient, which is something that we heard indirectly from Dr. Lewin at Emory with Lean as their change strategy. And so we at the AMA have developed an extension of our burnout assessment, what we call an organizational biopsy. And it looks not only at burnout, but also the culture of wellness. So it looks at leadership, culture, trust, sense of connection that the individuals within the organization have, and then efficiency of practice, looking at team structure and function. And we're also doing quite a bit of work using the metadata from the EHR to look at work outside of work or pajama time and teamwork for orders and time on documentation. And I think by really being able to pull back the curtain and characterize the organization, both its culture and its practice efficiency, that we will be able to deliver better care. So I think efficiency of practice is actually an equity issue for the medical assistants, nurses, and physicians who are practicing, but also for the populations that they serve. And unfortunately, my suspicion is that the team structure and function is not as strong in those organizations that are serving our patients of color or people of higher needs. And so if we can start to characterize in a post-COVID world, the culture and the efficiency of an organization, I believe that that's a way we'll be able to drive improvement.
Thank you, Chris. Thinking back to the conceptual model that Pascal shared earlier in the day, well, as an education person, I sort of saw the arrow that went across the bottom of the model around learning and improvement, and both organizational learning improvement, and I'm also going to generalize that to systemic learning and improvement. So, you know, we've now covered the basis to talk about the data that we produce and might consume, but I'd like to build a connection between our session and the previous session. So I'd like to go around our panel again and ask you, how can healthcare leaders foster the opportunities that each of you have discussed? What is the imperative for healthcare leaders with regard to, and it seems like we've broadened, it's not just clinician well-being, but it's really the well-being of our healthcare system under this stress. So what should leaders do? Bev, let's start with you again.
Well, you know, that's an easy one. Leaders always have to not just speak, they've got to do. And people are watching what they do and how they do. So you can have a conversation, pull together your team and your hospital, but if your behavior, if the things are still the same when you really actually make decisions, I think that everyone's going to be watching the actions and measure. That's where you can get the measurement, is not just the speaking, but the actions of our leaders. I heard some very positive, strong leaders, you know, that some of them I know, some of them I don't. And we've got to get those who are not that strong and not that positive, because they've got to come along too. And they've got to see the models up there and say, oh, we want to be like that when we grow up. Our organization, our hospital, or our school of nursing, or our medical school. I think there's room to grow. And I think sometimes we don't understand the power that we have when we set out models for others. The NAM is one great place to set out models for others. And I think that that's what this meeting, total meeting, is about. to hear and to see what we're going to do about this. And that's the real question. Post-COVID, are we going to be any different? Are we going to be better? Are we going to just have a lot of talk? Can we demonstrate some changes that we're going to do? Is there a way of more collaboration between providers, nurses, physicians, social workers, pharmacists? Can we actually present that and show that as a model? And of course, put a little lack of racism in there, or talking about racism and structural racism, that instead of, well, I wasn't born when that happened. And so how can how can it be me that it's that structural racism when it's in the building, in the framework, and whether you like it or not, you're born into it. And so we all have a responsibility to acknowledge it, own it, change it.
Thank you, Beth. Chris, what are your thoughts about the imperative for leadership around these issues?
Yeah, I've been thinking about the learning organization, both at the QI level, at the individual organization, and then at the science level for our system. So I think at the QI level, it's important that every organization commit to regularly measuring professional well-being and its antecedents, such as some of the things like work outside of work, and then to establish shared accountability among the executive leadership team for those results. Because I think the chief technology officer, the chief compliance officer, and others make different decisions if their responsibility includes increasing the opportunity for joy, purpose, and meaning in work for the workforce, and not just to protect the organization, for example, from an audit failure. And so I think those are ways we can structure in the forces toward the quadruple aim. And then on the health system level, I think we just need to invest in practice science. We spend $100 billion a year on new tests and treatments, and a tiny, tiny fraction of that on improving the delivery model for those tests and treatment.
Thanks, Chris. All right, Lisa, you have the last word. What's the imperative for leadership around these data and opportunities for improvement in the future?
I think fundamentally healthcare will always be people caring for people, from the technology and all of the resources that are available today to those who were treating the victims of the 1918 flu pandemic, who had just mostly their good wishes. I think we need to ensure that all of us, leaders, frontline, all of us are working together with this renewed commitment that we all connection we have about making care better, and really looking at and analyzing what are the things that we really need to keep, what makes care better for the patient, what makes care better for the caregiver, and how do we better streamline those conversations so that we can get to an answer. So, I mean, that feels very high-minded and very Pollyanna, but I think this is an opportunity we can't waste, because everyone is having these conversations. We are bringing together a panel talking about all of these activities and all of these impacts. And now is the time to really focus on how do we put the science in place, as Chris mentioned? How do we make sure that we're talking about all of these things together? So with that, I'll turn it back to you, Steve.
Terrific. So again, I want to thank our three speakers, Dr. Chris Sinsky, Dr. Beverly Malone, Elisa Arespacochaga. This has been a terrific discussion, grounded, I think, in data and science, but providing some really far-reaching thoughts for us about how we address this, not just now, but sort of ongoing. So I'm going to, a little early, I'll check in to see if Tim Brigham is ready for the next session. Tim, are you there? Tim, you're now going to begin with reflections and closing remarks.